Okay, let's unpack this. Today we're diving deep into scleritis. It's an inflammatory condition of the eye.
That's right, specifically the sclera, the tough white outer layer.
Now, it might sound a bit obscure, maybe not something you hear about every day, but understanding scleritis is really quite crucial.
Uh-huh. Because although it's rare, it can be very serious. We're talking potential vision loss.
Exactly. So our mission today is to pull out all the essential info on scleritis. Everything from, what it is right through to complications, all geared up for effective revision.
And we'll try to weave in some memory aids too, help make it stick.
Definitely. So let's start right at the beginning. What is scleritis technically?
Okay, so technically it's an inflammation, specifically of the sclera. Think of it as the eye's protective tunic, that white part.
And you mentioned it can be serious.
Yes, absolutely. It's not just a surface redness. The inflammation goes deep and can genuinely threaten sight if it's not managed properly.
Right, and I understand there are different types. It's not just one single condition.
Correct. We mainly split it by anatomy, where it is in the eye.
Okay.
So you've got anterior scleritis, that's the front of the eye. That's the most common type, maybe 90% of cases.
90%, wow. Okay.
Yeah. And then there's posterior scleritis affecting the back of the eye. That's the other 10%. It's less common, but they can sometimes be more visually threatening.
Makes sense, affecting the back of the eye. And within that anterior type, the common one, are there more divisions?
Yes, there are subtypes there too, and they're important because they behave differently.
Okay.
You've got diffuse anterior scleritis, that's pretty common within the anterior group, and generally the sight prognosis is reasonably good.
Okay, diffuse.
Then there's nodular, think lumps or nodules. This one tends to come back, recur, and it can potentially progress.
Right, nodular recurrence risk. Got it.
But the really serious one, the one you really need to be aware of, is necrotizing scleritis.
Necrotizing sounds bad.
It is. Necrotizing means tissue death. So you get severe pain, actual destruction of the scleral tissue, thinning, and it can even spread to involve the cornea. This needs urgent, aggressive treatment.
Urgent. Okay, so diffuse, nodular, and the critical one, necrotizing. Is there a grading system?
There is a sort of 1-to-4 grading system, but it's not very standardized across different places.
So maybe less critical for revision?
Probably.
Yeah.
The key takeaway on types is that diffuse and nodular are the ones you'll see most often. But necrotizing, that's the emergency. Early, aggressive treatment is vital.
Okay, maybe a memory tip here.
How about, think scleritis, inflammation of the sclera, the sclera. Helps link the name to the part affected.
Scleritis. I like it. Okay, so what actually causes this? What's the etiology?
Well, that's often the tricky part. In many cases, the exact cause isn't identified. It's idiopathic.
Right.
But the strongest suspicion, and where a lot of evidence points, is towards autoimmune processes. The body's immune system basically gets it wrong and attacks the scleral tissue.
Ah, okay. So it's often linked to other conditions then? Systemic stuff?
Very often, yes. It's not usually just an isolated eye thing. Rheumatoid arthritis is a big one, a really common association.
Rheumatoid arthritis. Okay, what else?
Vasculitis, it's inflammation of blood vessels. Also various connective tissue disorders, kind of as a general category. Lupus, for example.
So autoimmune conditions featuring strongly.
Definitely. But the list is actually quite broad. You can see links with things like gout, Churg-Strauss syndrome, syphilis, even things like previous eye surgery, TB, local infections, Lyme disease.
Wow, quite a range.
Yeah, fungal scleritis, sarcoidosis, hypertension, parasitic infestations, lymphoma, trauma, even some medications like bisphosphonates.
So the crucial point here is that scleritis might be the first clue.
Exactly. It can absolutely be the presenting feature of a hidden systemic disease. That's why a thorough workup is so important.
Right. So that classic exam question. Patient presents with scleritis, most common underlying condition.
Rheumatoid arthritis. That's the one to have top of mind.
Good to know. And does that tie into the risk factors then?
It does, perfectly. The risk factors really mirror those associated conditions.
So having a history of autoimmune disease like RA or lupus puts you at higher risk.
Precisely. That's a major risk factor. Also, having had scleritis before makes you more likely to get it again.
Makes sense. Any genetic link?
There's thought to be, yes. Certain genetic factors might predispose some individuals, but it's complex. But mostly think existing autoimmune or systemic disease in previous episodes.
Okay, let's switch gears slightly. Pathophysiology, what's actually happening at the tissue level? Keep it concise for us.
Okay, concisely. It's inflammation in the sclera. This inflammation causes structural changes. It leads to the tissue thinning out.
And cellularly.
Cellularly, you get immune cells rushing in T cells, macrophages. They release inflammatory mediators, cytokines, chemokines, and these chemicals drive the inflammation and the damage. Vessel dilation is also a key feature.
Inflammation, thinning, immune cells. Got it. Now, clinically, this can present as a red, painful eye. How do you differentiate it from other things? What are the key differential diagnoses?
Yes, the differential. Crucial, because other things look similar. Top of the list is probably episcleritis.
Episcleritis, how's that different?
It's also inflammation of an outer eye layer, the episclera, which is more superficial than the sclera. It's generally much milder, less painful, and doesn't usually threaten vision in the same way scleritis can. Distinguishing them is key.
Okay, so episcleritis is a big one. What else?
Well, you've got your common red eye, causes like conjunctivitis, also uveitis, which is inflammation deeper inside the eye in the middle layer, and of course, ocular infections.
Any tips for remembering the difference?
Maybe think about the pain. When you consider red eye differentials, scleritis is often the one with that really severe, deep pain. And the redness itself can sometimes have a deeper, almost purplish or violaceous hue, not just bright red like conjunctivitis.
Pain and color. Helpful. What about how common this is? Epidemiology, particularly in the UK.
Right, epidemiology. It is rare. Prevalence estimates vary a bit, but maybe around 0.3 to 1.6 cases per 100,000 people.
Okay, not common at all.
Not common. And interestingly, fitting with the autoimmune link, it's seen more often in adult females. And as we've said, higher prevalence in people with known autoimmune diseases. Again, rheumatoid arthritis and granulomatosis pop up frequently.
And you mentioned it can be the first sign of a connective tissue disease.
Yes, absolutely worth repeating that. It can be the initial presentation. So incidence, the rate of new cases is maybe around 3.4 per 100,000 per year. Prevalence, total cases, maybe around 5.2 per 100,000. Still low numbers overall.
Okay. Let's move on to how it actually looks and feels for the patient. Clinical features, signs, and symptoms. What's the absolute hallmark?
Pain. Severe eye pain. That's the big one.
Describe the pain. Is it just like a surface irritation?
No, typically not. It's often described as a deep, boring, aching pain. Really quite intense.
And does it have any specific patterns?
Yes, it often gets worse at night. That's quite characteristic. Can really interfere with sleep. And sometimes it radiates to the forehead, the jaw, the temple area.
Wow, seems debilitating. What else besides pain?
Redness of the eye, obviously. Photophobia, being really sensitive to light. Blurred vision is common too, and tearing or watering of the eye.
Okay. And what might an examiner see? Signs?
Well, the obvious red eye, as we said, usually more painful than episcleritis, though sometimes the pain can be milder, which is tricky. Watering and photophobia are common signs too, and you might find a gradual decline in their measured vision.
Okay. Maybe a mnemonic for symptoms?
Let's try SPRINT. S-P-R-I-N-T. Severe pain, photophobia, redness, tearing. And the T could also remind you vision might be threatened or blurred.
SPRINT. Severe pain, photophobia, redness, tearing. Nice. So someone comes in with these features, what investigations are needed?
Right. Investigations, it starts with a really thorough eye exam by an ophthalmologist. That's essential.
What does that involve?
Assessing their visual acuity, properly evaluating how the sclera looks, using a slit lamp, measuring the intraocular pressure. The whole works.
And given the systemic links.
Exactly. You have to look for underlying causes. So laboratory tests are usually needed. The assumption should be there is an underlying cause until proven otherwise.
Okay. What kind of lab tests are we talking about?
It depends on the clinical picture, of course, but common ones would be things like a full blood count, FBC, checking inflammatory markers like ESR and CRP.
ESR, CRP.
A rheumatoid screen, definitely. Syphilis screen. Maybe a urine dipstick looking for blood or protein, which could indicate kidney involvement in some systemic diseases.
Any imaging.
Sometimes. A B-scan ultrasound of the eye itself can be useful, especially for posterior scleritis. Maybe chest x-rays, sacroiliac joint x-rays, or even MRI or CT of the sinuses or orbits if you're suspecting specific associated conditions.
And you mentioned vasculitis earlier.
Yes. Critically important to rule out systemic vasculitis, because some forms are life-threatening. Investigating for that is paramount if there's any suspicion. It often means working closely with other specialists, like rheumatologists. It's a team effort.
Right, collaborative care. Makes sense. Okay, so you've done the exam, the tests, you've got the diagnosis. How is scleritis managed, say, in the UK? What are the goals?
The main goals are pretty clear. Reduce that inflammation, relieve the patient's pain, and ultimately preserve their vision. prevent damage.
And the main tools to achieve that?
It's often a multi-pronged attack. Systemic treatments are usually needed. So corticosteroids, often orally,
Yeah.
immunosuppressive medications to dial down the immune system, and NSAIDs, non-steroidal anti-inflammatories, can help with pain and some inflammation.
And tackling the underlying cause.
Absolutely fundamental.
Yeah.
If you find an underlying condition like rheumatoid arthritis or vasculitis, managing that is key to controlling the scleritis long-term.
So suspected cases need quick referral.
Definitely. Immediate ophthalmology referral, and often, as we said, co-management with rheumatology or other relevant specialties.
Does the treatment differ much depending on the type of scleritis?
Yes, it's tailored. For the more common diffuse and nodular anterior types.
The non-necrotizing ones.
Exactly. You'd usually start with oral NSAIDs, high dose, like ibuprofen, 400 milligrams 4 times a day.
And if that's not enough?
Then you'd likely move to oral steroids, like prednisolone, often starting at a fairly high dose, maybe 80 milligrams a day, then tapering.
What about steroid injections around the eye?
It's controversial. Some use subconjunctival or periorbital injections, but there are risks, especially scleral thinning. Not usually first line.
Okay. What if steroids don't work or can't be tapered?
That's when you bring in the immunosuppressives, methotrexate, azathioprine, mycophenolate, drugs like that. Or even the biological agents, the BRMs, like infliximab or adalimumab, especially in difficult cases.
And surgery?
Only really for complications if they develop cataracts or glaucoma from the inflammation or the steroid treatment.
Right. Now, what about the scary one, necrotizing anterior scleritis?
That needs the big guns straight away. Systemic steroids and immunosuppressives from the start. You need to shut down that inflammation fast.
Is cyclophosphamide used here?
Yes, especially if it's linked to systemic vasculitis, like granulomatosis with polyangiitis.
Yeah.
Cyclophosphamide is often the first choice immunosuppressive in that scenario.
And surgery for necrotizing?
Potentially, yes. If the sclera thins so much that there's a risk of the eye perforating, you might need a graft to patch it up.
And those periocular steroid injections?
Big no-no in necrotizing. Absolutely contraindicated. Risk of making the thinning worse, leading to perforation.
Okay, good point. What about scleromalacia perforans? That sounds related.
It is. It's a type of necrotizing scleritis, but often without much inflammation or pain, just progressive thinning.
Yeah.
It's very difficult to treat effectively. There's no specific cure. You might try various drops or systemic meds, but often surgery is eventually needed just to keep the eye intact.
Difficult. And posterior scleritis at the back.
Treatment varies. Younger patients might respond well to just oral NSAIDs, but in older patients, or if vision is threatened, you manage it more like the anterior non-necrotizing types. So systemic steroids, maybe immunosuppressives, BRMs like infliximab are also being used more now in specialist centers for posterior cases.
And just to reiterate that key point about vasculitis.
Yes, absolutely crucial. If the scleritis is linked to a potentially lethal systemic vasculitis GPA, polyarteritis nodosa cyclophosphamide is typically the go-to initial immunosuppressive treatment.
Got it. So with all these treatments, what's the overall outlook, the prognosis?
It really varies. It depends heavily on how severe the inflammation is, how widespread it is, and crucially, whether there's an underlying systemic disease and how well that's controlled.
So early diagnosis helps.
Definitely. Early diagnosis and getting the right treatment quickly improves the chances. But relapses are pretty common even after things seem quiet. Patients need to be aware of that.
Does prognosis differ by type?
Yes. For non-necrotizing scleritis without major complications, the visual prognosis is generally pretty reasonable.
Okay.
But for anterior necrotizing scleritis with inflammation, especially if linked to vascular disease, the prognosis is much poorer visually. It's a severe condition.
And posterior scleritis?
In patients over 50, posterior scleritis often signals a higher chance of having a systemic disease and carries a greater risk of visual loss compared to younger patients.
And prevention, can you prevent it?
Unfortunately, no specific way to prevent scleritis itself from starting. The focus is really on controlling any underlying disease if one is found, and treating the scleritis flare-ups promptly and effectively to minimize the risk of permanent vision damage.
Right. Manage the underlying condition. Lastly, what are the potential complications we need to be aware of?
Well, the big one is vision loss, obviously. That's the major concern.
What else can happen to the eye structure?
You can get thinning of the cornea, or even perforation in severe cases. Glaucoma raised pressure inside the eye is a common complication. Cataracts can develop, either from the inflammation or steroid treatment, and inflammation can spread to other parts of the eye, like uveitis.
And complications directly from the scleral inflammation itself.
Yes, the sclera thinning we've talked about is a direct result. You can get ischemia, reduced blood flow to the front part of the eye, raised intraocular pressure leading to glaucoma. Retinal detachment is a risk, especially with posterior scleritis, uveitis as mentioned. And in the worst case scenario, you can end up with phthisis bulbi.
Phthisis.
Yeah, it's basically atrophy or shrinking of the whole eyeball, a very severe end-stage outcome.
Okay, so quite a list of potentially serious complications.
Definitely reinforces why it needs careful management,
So let's wrap this up. Key takeaway.
I'd say. Scleritis rare, but potentially very serious. It's an inflammation of the sclera, often linked to underlying systemic autoimmune diseases. Prompt diagnosis, looking for those underlying causes, and appropriate management, often involving ophthalmology and rheumatology, are absolutely vital to preserve vision.
And understanding those different types, diffuse, nodular, necrotizing, and the different treatment approaches is key for revision.
Exactly.
Okay, that brings us to a final thought for you, our listener. Considering the strong link we've discussed between scleritis and systemic conditions, what other eye problems, things that seem localized just to the eye, might actually be whispering hints about wider health issues needing investigation? Something to ponder.
And for more revision resources on this and other ophthalmology topics, definitely check out PassTheMSRA.com.
And freemsray.com as well. Lots of great material there.